Today, the topic I have chosen to talk is management and prevention of childhood obesity. As you all know, childhood obesity is a global health concern. 10 to 20% of children in the world are obese, and the prevalence has increased over the past 4 decades by nearly 8-folds among children and adolescents. And the majority of overweight and obese children live in developing countries at the moment, with a rate of increase 30% higher than Western countries. So these graphs illustrate, these are the trends over the past 3 decades or 3.5 decades, where the blue and green zones represent the developed countries, North American, European countries, where the obesity trends are plateauing among children and adolescents. And the red and orange zones represent the developing countries, specifically Asian, African countries, where you can see an exponential rise in the rates of overweight and obesity among children and adolescents. So we are the ones who are facing this, the great epidemic of childhood obesity. So where are we in our country? So our prevalence rates of overweight and obesity also match with the world figures. So these are some surveys conducted in different parts of the country. And in Kandy also we conducted a survey among urban schools where we found overweight at a rate of 14.6%, obesity at 6.8%, and there was a prevalence of 11.7% of metabolic syndrome among our children. So we are in par with the worldwide figures. So with that background, I will be going through my presentation, focusing on the definitions, the contributory factors towards obesity, the comorbidities, and how to evaluate a child with overweight or obesity, and the principles of management, and the current trends in the prevention. Right. So most of you must be aware of the how we define obesity. We utilize either CDC charts or the WHO charts. According to the CDC, they talk in terms of centiles. Between 85th to 95th centile of body mass index, we define as overweight, and above 95th centile as obesity, and more than 35 as severe obesity. According to the WHO charts, we go by the standard deviations or SDs. So more than between +1 to +2 is overweight, and more than +2 SD we define as obesity. So generally in clinical practice, we mostly use the centile charts rather than the standard deviation charts. Okay, so talking in terms of the causality of obesity, we mostly see children with simple obesity, which is diet and lifestyle related, whereas pathological obesity is usually secondary to an underlying primary etiology. So during my lecture, I will be focusing more on simple obesity rather than pathological obesity, because pathological obesity management is focusing on the actual etiology. Right. So what contributes towards simple obesity or primary obesity? So it's the diet and lifestyle mostly, contributed by the heredity as well. I mean, always there is about 40% risk from the genetic makeup of the child. So in addition, the lifestyle, the westernized food, including high fat, high carbohydrate, and higher energy dense diet, with sedentary lifestyle, increased screen time, reduced physical activity, all contribute. So here you all see the obesogenic environment our children live nowadays in our society. So all that contributes to the current epidemic of obesity. And generally, children with simple obesity are tall and obese because their growth potential increases because of increased nutrient intake. Secondary obesity, of course, is usually caused by an underlying etiology like an endocrine problem like juvenile hypothyroidism, hypercortisolism, growth hormone deficiency, and so on. And also, there are various genetic syndromes associated, which are primarily associated with obesity, like trisomy 21, Prader-Willi, Bardet-Biedl syndrome, and so on, and also acquired CNS conditions like space occupying lesions or post craniotomy, hydrocephalus, and so on. And certain medications like long term steroids can also um, contribute towards secondary obesity. Okay, now before we proceed further, I will quickly talk you through the weight regulation and energy metabolism in an individual, and also how it gets disrupted in obesity. So whatever the cause, either simple or secondary obesity, the weight regulation mechanism gets disrupted. In an individual, weight set point or the weight trajectory in a growing child is maintained within a range depending on the genetic makeup of the individual and also the basic lifestyle factors like food intake and lifestyle. And the central controlling center is the hypothalamus, the arcuate nucleus of the hypothalamus. And the key hormones, as I'm showing here, the key hormones are leptin and ghrelin. And there are so many other neuropeptides which are involved in controlling the hunger and satiety. So basically, when the body is lacking substrates, the hunger hormones increase, the ghrelin, and also stimulates the hypothalamus to secrete hypothalamic ghrelin, which will increase the appetite. So the individual will take food, and when the substrate level increases, the adipose tissue secrete leptin, to which increases the satiety and reduce the appetite, and that is how the energy balance is maintained. Now, what happens when a person continues to overeat, right? So if we start here, when a person overeats, just ignoring the inner signals like satiety and hunger, like when you eat in front of screens, and when you eat in get-togethers and so on, you just ignore your inner signals, right? So when you go on eating like that, there will be increased calorie intake, and you tend to gain weight, and your adipose tissue um, multiplies, the adipocytes multiplies, and will increase the leptin secretion. So leptin is primarily secreted by the adipocytes. So now when the adipocyte population increase dramatically, there will be a chronic inflammation that sets in, right? So that results in development of leptin resistance. And this hypothalamic, the signaling mechanism gets disrupted. So there is no satiety. So a person who starts overeating and develops leptin resistance will continue to overeat, and this becomes a vicious cycle. Okay, so that's what happens in obesity. So why are we so concerned about children becoming obese? Is because without intervention, obese children are likely to stay obese into adulthood and develop non-communicable diseases at a very younger age. For an example, development of fatty liver or non-alcoholic fatty liver disease, dyslipidemia, orthopedic problems like bony deformities like knock knees, bow legs, and even slipped capital femoral epiphysis, and a lot of psychosocial issues, right? And in addition, metabolic syndrome, they all can develop during childhood itself. So we are really worried when children become overweight and obese. Right. So we need to manage them. So management of an overweight or an obese child are basically uh, focused on managing through lifestyle interventions, so which comprise of the dietary modifications and increase in physical activity, behavior counseling, and management of complications. Right. So it's diet, physical activity, behavior, and management of complications. So now, to implement a proper management program, we need to carry out an evaluation to identify what has gone wrong with this child's diet, what has gone wrong with this child's physical activity, what is wrong with the behavior, and what complications are already existing in this child. So that is why we need a proper evaluation. So I would say that the evaluation has to be targeted towards management. Because unlike in any other chronic illness like bronchial asthma or diabetes, where you treat with medications, here it is lifestyle interventions. It's the diet, it's the physical activity, it's the behavior we are going to manipulate, right? So it's not easy. We are trying to intervene with the child's existing lifestyle. Um, Therefore, we need to evaluate them thoroughly to identify what are the points that we need to intervene specifically, right? So we'll see how should we do that, right? So the dietary history is extremely important to identify at what point we should intervene. What are the wrong dietary habits that we can substitute with healthy dietary habits? For an example, the number of meals is extremely important in a school going child. So if you talk to a few children who are at different grades, you will find out a child might take breakfast at home and they go to school. Certain schools offer breakfast as well. Um, so the child may consume that. And during the school interval, the child consumes the packet of rice, which is given by the mother from home. And then after school, when the child returns home, again, the child will consume a plate of rice. And in the night also, another main meal. So altogether, a school-going child might be taking 4 or 5 main meals, especially with obese children, because they have a big appetite as well. Right. So the number of meals is an important thing that we need to reveal in the history. The school meals, as I said, and the eating trends, like, eating with friends and going to the school canteen and, you know, uh, consuming junk food or frequent snacking, things like that are very important to find out. And the food rewards. Now, it's a trend in our society that a child's achievements are generally celebrated by food rewards. Either you give a slab of chocolate or take the child out to have a dinner or some treat. So rather than giving any other other gifts like books and things like that, so there's a tendency to go um, um, for a meal out. Right. So these trends in the diet have to be identified so that you can give the proper advices. Right. So same with physical activity. The child's sitting time, the screen time is important. Some children go on watching television for hours and hours. So the parental control over screen time, and sometimes, the past 2, 3 years of online activity, children tend to do their studies online, and in addition their hobbies are also based on screens like video games or phone games or whatever, so they spend a lot of time on screens, right? um, and their outdoor playtime is drastically limited. And also in urban families where they live in apartments or in very restricted areas, their opportunities for activity may also be restricted. Now, in our lifestyle intervention programs, we are going to advise this child and the family to engage in more physical activity. But then to find out the opportunities are minimum, that they don't have a compound uh, and they don't have safe roads to cycle, right? So we need to find those things out. And the disabilities in the child. An obese child may have their specific difficulties like joint pains. They may have bony abnormalities like knock knees or bow legs. They can have backache. And also, when a child is obese, their center of gravity deviates, right? So they can topple very often. So the normal exercises, and any individual does may be difficult for an obese person to do, right? So we need to take those things into consideration. Right. Other lifestyle factors involving the family, like the parental motivation towards reduction in the weight in the child, whether the parents understand that there is a problem with their child's weight, right? Their food habits, their eating habits, and takeaways. Um, when both parents are working, sometimes um, especially the dinner may be not prepared at home, parents may be bringing from outside, right? So outside food may be very fatty meals, refined carbohydrates, and so not healthy for an obese child when we are trying to lose weight, right? So frequent social gatherings may also expose the child to unhealthy food, right? And also the presence of extended families. Now, the problem with extended families is now when we advise a child and the family to towards lifestyle interventions, giving them targets to reduce weight, like 10% weight loss over the next 6 months, right? When there are extended families around, they may not understand what's going around. And, sometimes the grandparents, aunts and uncles may sympathize and, try to offer food for these children, right? So we need to find that out as well, because we need to address this issue. Otherwise, it will result in a failure. Right. Okay, right. Then we need to perform a psychological assessment of the child to find out whether what sort of insight the child has regarding the body image, right? And whether the child is subjected to bullying and the child is upset about going to school, moving out with friends, and so on. Um, how has it affected the child's self-esteem? Is there any element of depression, especially in adolescent girls and boys? And finally, whether the child is ready for a change. This is extremely important, the readiness of the child for a change. To implement a lifestyle management program, the motivation of the child is important, especially when it's a teenager or an adolescent. A small child, like, less than 10 years of age, of course, it will be more the parental control. But when the child is bigger, the child has to take a lot of responsibility in achieving a healthy weight. So therefore, the readiness in the child's mind towards a change is important to reveal. Okay, right. So then once the evaluation is complete, I didn't talk much about complications here because I've gone through a slide on complications. Um, Now we are ready to implement the lifestyle modification program. So it's a kind of secondary prevention once the child has become obese, right? So now we are trying to achieve a satisfactory body weight with achieving a normal height velocity. We are not going to compromise on the child's nutrient intake, but we are only trying to make the child's meal healthy. So we aim at reducing the BMI while not compromising on the height velocity of the child, right? So, and normalize the metabolic abnormalities that may be existing at the time of detection of obesity. And our final aim is to prevent the child becoming an overweight adult, right? Okay. So, um, considering the age of the child, the recommendation is to go for weight maintenance in less than 12-year-old children because they are constantly growing. It's difficult to achieve a weight reduction. So, we aim at maintaining the same weight over 6 months period. Whereas in children more than 12 years, we aim at achieving 10% weight loss over 6 months. Having said that, if a less than 12-year-old child is having metabolic syndrome or obstructive sleep apnea kind of uh, life-threatening complications due to obesity, still we can achieve weight reduction under supervision, under careful supervision. Okay, so the basic dietary modifications are aimed at reducing fat intake by 30% less, reducing by 30%, and out of that saturated fat by 10%, and reduce the portion size, right? And increasing the fiber intake and zero sugar. So these are some of the basic changes we are going to address. And at the outset, we need to talk through the basic rules of uh, meals with the child. So every child should take breakfast. When we advise regarding weight reduction, some children decide not to take the breakfast, right? Which is not good. So breakfast is the most important meal of the day. So the breakfast has to be taken um, before 9 o'clock, right? Okay. So lunch is before 12. So if a child takes homemade food to have during the school interval, so that is the lunch. So the child cannot come home and have another lunch at 1:30 or 2 o'clock, right? Only three main meals a day and avoid unhealthy snacks. And no eating in front of screens. So these are some of the basic rules they have to abide by when they go through a lifestyle management program. Right? And also we should give an idea to the child, what are the energy rich food, what are the low energy foods, right? So that, they have a conscious consumerism, right? So they are conscious on what they eat, right? So a cookie may appear very small, but it has a very high calorie content, whereas a banana may appear, quite bigger than a cookie, but it has less calories. So likewise, in an age appropriate manner, we have to start educating the child. Now, once you start lifestyle interventions, we are going to follow up the child for a longer period of time, for at least for 1 year, right? So stepwise, you need to educate the child regarding the calorie density of food items. So this is important for the rest of the life for the child. Right. And this is what we are going to introduce with regard to weight reduction. This is the healthy plate for weight reduction purposes. So we divide the plate into two and one half into another two. So one quarter will contain the grains or the carbohydrate. Um, and the other quarter should contain a protein-rich food. The half of the plate should contain vegetables and salads, malung, and so on. And the vegetables cooked without coconut milk, right? So I'm talking in terms of weight reduction. So this is the healthy plate we are going to introduce. Right. And regarding the portion sizes, so in our culture, it's mostly the large portion is carbohydrates, right? Whereas the consumption of vegetables and grains, those are quite less. So we need to talk about the portion size with the child, and also to start eating from the vegetable side, right? So that the child will achieve some satiety halfway through the meal. So Okay, and here the substitutes, culinary habits, broiling or boiling rather than deep frying, and also non-fat substitutes in spite of full cream milk, and whole meal products, um, in place of refined carbohydrates. Although the carbohydrate content will be similar, but the satiety is achieved through whole meal products more easily. So these are good substitutes. Right. And also talking about the high calorie food. Um, Now, this is an example. If a child consumes a large piece of cake, right, which will contain about 550 kilocalories, the child will have to obviously um, you know, engage in vigorous exercise of 1 hour and 40 minutes to burn that off, right? So it will be probably better to avoid that, right? Rather than, you have to exert so much to get rid of the energy that you have consumed in a piece of cake, right? And these snacks have to be substituted by healthy fruits or yogurt, things like that, rather than eating bakery products, pastries, things like that. If you talk to children, you find out the common snacks for children have become vade and pastries, buns, and so on, rather than fruits. One thing may be storage of fruits, and even the cost is high. But with when we aim at weight reduction, we'll have to substitute unhealthy snacks with healthy ones, of course. Right. And this is something the Western countries have adopted, where they have advertised in their schools 5210, 5 fruits a day, less than 2 hours of screen, 1 hour of physical activity, and zero sugar. So they advertise this everywhere in schools, notice boards, and so on. So children look at this, right? So, they think, why are we encouraged to do so? So these are some good initiatives for us as well. Right. And drink water instead of sugar sweetened beverages, and avoid diet versions. Diet versions are not suitable for children. So these beverages contain high amount of sugars, so they have to be discouraged. Okay, so that's about the diet and the physical activity recommendations. So adults, of course, it's 30 minutes of moderately intensity physical activity 5 days a week, right? But 1 hour for weight loss. For children and teenagers, it's 60 minutes per day. Every day they have to engage in moderately vigorous physical activity. So it could be either fast walking, running, cycling, skipping, or engaging in competitive sports, dancing. So anything, but it has to be minimum of 60 minutes a day. For a smaller child, it has to be at least less than 5-year-old, 3 hours per day of physical activity. Right. So how can we increase the physical activity? Now we have to talk that with the child and arrive at collaborative decisions depending on the child's abilities, availability, opportunities, and considering everything together. So options like walking to school, getting down from the school bus about 500 meters before the school gate and walking, right? Avoiding stairs and escalators. So all these options you have to talk with the child, right? So the child is obviously encouraged to do so, because the child is the one who ultimately decides, right? So then the behavior. So we have to encourage the child to make some changes in their behavior. right? So we should never use the body image as the stimulus to change, like, telling the child your figure is so bad, right? You have to wear extra large clothes, right? So don't you want to reduce your weight? So we should never comment like that, right? So we should only talk about the the uh, the medical aspect of it, the health, right? Your weight is not very healthy, right? So you have to reduce your weight to become more healthy. Otherwise, you will develop these consequences, right? And we need to set the goal of weight loss with the child, like 10% weight loss over 6 months, and we need to decide how the child is going to achieve that, right? Self monitoring can be allowed in older children, but under adult supervision. Otherwise, the children can go to an extreme end, becoming anorexic, especially adolescent girls. If they go on measuring their weight every week or every day, right? So that's not going to be right. So it's under adult supervision, right? And also the stimulus control, like, when they are in a gathering among friends, when they snack together. So how can a child avoid that? Right? For that, the coping strategies, stress management, all that is important. Right. So pharmacotherapy has a very limited value in childhood obesity. Right. Orlistat is the only recommended medication for reduction in fat absorption, which is only recommended in children more than 12 years with morbid obesity when the BMI is more than 35 or 40. Um, they are handicapped because of their obesity, right? We can use Orlistat. When we prescribe Orlistat, we have to hand in hand prescribe the fat soluble vitamins as well. The problem with Orlistat is that it can cause a bit of steatorrhea, bloating, and some discomfort. Metformin is indicated for non-alcoholic fatty liver disease, but not for weight reduction purposes. And there are many other emerging therapies like ketogenic diet, intermittent fasting, topiramate, and yeah, those things are still under investigation in children, so not recommended so far, except for bariatric surgery. Adolescents can undergo bariatric surgery. Right. However, the meal replacement with things like Optifast, very low calorie meals, and herbal remedies, high protein diets are not recommended for pediatric weight management. Right. Okay. So now we have talked through the dietary modifications, physical activity, and behavioral management. And then, at the same time, we need to address the complications the child is having. Like, we need to assess all the metabolic abnormalities, the lipid profiles, blood sugar, ultrasound scan liver to detect fatty liver, the liver enzymes, thyroid profile, right? And 2D echo and blood gas if there are features of obstructive sleep apnea, and of course in girls, presence of polycystic ovarian syndrome. So these are some of the investigations, but depending on the problem your patient has, you will have to uh, do appropriate investigations, right? So touching upon the childhood metabolic syndrome, because it's important, we diagnose after 10 years of age. The prerequisite is the presence of central obesity, defined as waist circumference more than 90th percentile for age and sex, with two of the four factors that I'm showing here. 2 out of 4, triglycerides more than 150 milligrams per deciliter, HDL cholesterol less than 40, blood pressures, and uh, random blood glucose, right? So these are the criteria to diagnose childhood metabolic syndrome. This is the IDF criteria. There are certain criteria which which gives a cutoff as 100 of triglycerides. Right. Okay, so the clinical relevance of the metabolic syndrome is that, it talks of dyslipidemia, low HDL and high triglyceride. We call that uh, atherogenic dyslipidemia. So childhood obesity, right, is associated with dyslipidemia, and it is an important causative factor for atherosclerotic cardiovascular disease, which is the leading cause of death worldwide, right? Okay, so I'm going to talk a little bit about dyslipidemia over the next few slides. So we have established lipid profiles for children, right? So these are the acceptable ranges, and we have a borderline, right? And these are abnormal where we might decide to treat. Now, when you get a borderline result, we have to repeat the lipid profile and double check. Okay, so now how do we perform a lipid profile in a child? Fasting or non-fasting? Right. So always fasting lipid profile is superior because we cannot interpret all the parameters in a non-fasting lipid profile. For an example, we can't interpret triglycerides in a non-fasting lipid profile. So non-fasting is recommended only for general screening purposes, like universal screening, not for overweight or obese children. Right. So to perform a fasting lipid profile, the child has to be on a normal diet for 4 to 6 weeks, and then an overnight fast, preferably 12 to 14 hours, but at least 8 hours, right? Um, okay, right. So dyslipidemia, um, we, first focus on lifestyle interventions only. Whatever the dyslipidemia is, we don't start on medications at once. So we first try lifestyle interventions, low fat diet, physical activity, all that I have talked through earlier, uh, for 6 months. So in 6 months, we repeat the lipid profile. If still there are major abnormalities, we may consider lipid lowering agents, right? And also we need to consider whether there are risk factors for the child. There are high degree risk factors and moderate level risk factors. So if there are higher degree risk factors, we may have a lower threshold to start on treatment. So we'll just look at the risk factors, right? So there are so many risk factors here. Out of them, obesity, BMI more than 97th percentile is a high atherosclerotic cardiovascular disease risk factor. So within 6 months, if the lipid abnormalities are not getting corrected, we need to discuss with the pediatric endocrinologist and consider treatment. Similarly, moderate atherosclerotic cardiovascular risk factors, the overweight and obesity again is a risk factor among all these things, right? Okay, so we'll just skip this. It's not very important, right? Okay, so if the LDL is elevated, it's a very high risk for atherosclerotic cardiovascular disease. It could be elevated in not only in obesity, but also in familial hypercholesterolemias and so on, right? So still for all, we try lifestyle modifications first, right? Now, um, earlier I talked about the triglycerides and HDL, which are the hallmark features of obesity-related uh, dyslipidemia. But you may come across high LDL as well among obese children. Out of them, a few of them could be due to familial hypercholesterolemia also, right? So in such cases, you may find a positive family history of premature atherosclerotic cardiovascular events in first degree relatives, right? So if there is persistently elevated LDL, then the child may need lipid-lowering agents. So statin therapy, not commonly used, but can be undertaken in children more than 10 years with measurement of baseline liver functions and monitoring liver functions every 3 months, because they can develop side effects, right? And continue the lifestyle modifications and come off the statins as soon as possible. Right. So now with regard to management of child obesity, before I move on to some aspects of prevention. So in summary, a comprehensive evaluation is extremely important, on which we base our guidance uh, to implement the management. So it is individualized management protocol, which is multifaceted: diet, physical activity, and behavior, right? With intrinsic motivation and goal setting, which we have to uh, reiterate each time we meet the child, right? And we aim at weight maintenance rather than weight loss in children. Okay, right. So having talked about the basic principles of management, I thought I will touch upon the preventive aspects as well. Right. Now we talked about lifestyle interventions. So how successful are these lifestyle intervention programs? Now we put the child on lifestyle intervention program for about 6 months or maximum of 1 year. And we expect the child to learn the healthy lifestyle for the rest of the life, right? Okay, so what we observe is, children achieve an attractive weight reduction over 6 months to 1 year. But however, 70% of the lost weight can be regained over the next 4 years if the child does not stick to a healthy lifestyle, right? So therefore, it's not very easy. Even our weight management clinic, we found that 80% of children responded to lifestyle management within 6 months. Right? So, but the long-term weight control is the issue. So that means we need to move away from our secondary management or secondary prevention towards primary and primordial prevention. So to implement a primary or a primordial preventive program, we need to understand the origins of obesity, right? So that we can target the causal pathways. So why do children become obese in the first place? So genetics play about 40% role in causation of obesity. And in addition, we know the lifestyle, diet, environment also contribute in a major way. But now the research has found out um, childhood obesity results from in utero fetal programming of metabolic and weight regulating genes, which are heavily influenced by maternal obesity and excessive gestational weight gain. Not only these two, but also rapid postnatal weight gain of the child during the first 2 years of life, right? So these three factors, right? Maternal obesity and excessive gestational weight gain can lead to in utero fetal programming. And rapid postnatal weight gain also can cause further genetic programming and lead to childhood obesity. We call this phenomenon epigenetic modifications, right? So epigenetic modifications are modifications that happen in genes without changing the structure of the gene, but these epigenetic modifications alter the transcription of the expression of the genes, and especially the genes that are involved in weight regulation and energy metabolism, right? And result in development of non-communicable diseases later in life, right? So we'll see how that happens, right? So now we also face a large burden of maternal obesity in the world. Nearly 50% of women in childbearing age are obese. 15 to 20% of women starting pregnancy are also overweight and obese. And 20 to 40% of pregnant women suffer from excessive gestational weight gain, irrespective of their preconceptual weight. Right? So they may be having a normal BMI at the beginning of the pregnancy, but they gain excessive weight during the pregnancy. Right? So all these are risk factors for childhood obesity. So there are a lot of research showing that maternal BMI at the time of conception is a risk factor for obesity and also the gestational weight gain. Right. So what happens is now with maternal overweight and obesity, the the intrauterine environment changes. The circulating maternal metabolites like hyperglycemia, hypertriglyceridemia exposes the fetus to high substrate levels, and also the maternal hormones are altered. Hyperinsulinemia with insulin resistance, high leptin levels, right? The adipokines, which are important in energy metabolism, are also altered. So the intrauterine metabolic milieu is grossly altered, and that results in increased substrate transfer through the transplacental circulation into the fetus, right? And at the same time, these metabolic abnormalities result in these epigenetic changes of the genes that are involved in energy and weight regulation. These epigenetic processes affect the gene expression that are involved in organ growth, metabolic control, immune control, cell proliferation, and all that. Right? And after birth also, if there is unhealthy postnatal lifestyle, especially rapid postnatal weight gain, right, these epigenetic processes can continue and have a lifelong effect on an individual's life until old age, right? So these are the epigenetic mechanisms that are involved in the causation of chronic diseases in adult life. So this is the original Barker's hypothesis based on the Barker's hypothesis of fetal origins of chronic disease. Okay. So now with these maternal effects, what happens in the fetal genome is these are the epigenetic modifications. We call them. There are three key types of epigenetic modifications: DNA methylations, histone modifications, and microRNA changes. So in humans, programmed obesity principally occurs via DNA methylations, which is extensively studied in Western laboratories. Right? So these are some of the, cells and tissues that undergo epigenetic modifications like endothelial receptors, adipocyte population, cardiac myocyte hypertrophy, and also tumor necrosis factor alpha, like, cytokine secreting cells, right? They all undergo epigenetic modifications leading to, chronic inflammatory conditions. Right. So, what evidence do we have? I'm just showing you two interesting historical studies that showed these epigenetic modifications are in operation. So, this Dutch hunger winter is the world famous, famine that occurred in Netherlands in World War II. Right. Now, later on, researchers found the 60-year-old adults who are survivors of this famine who were born at the time of famine were suffering from obesity and various non-communicable diseases. And their epigenetic assessments found that they have epigenetic modifications in obesity related and NCD related genes compared to their same-sex counterparts who were born after the famine, who were not exposed to the famine. So those who were born during the famine, during the food shortage, right, have developed these epigenetic modifications. So that implies that the maternal nutrition affects the epigenetic modification. So I will elaborate on that in the next slide. So this is another study. This is a prospective study. It's a Gambian mother-child cohort. It's a follow-up of a cohort of mothers in a natural environment with uh, periods of food shortage and food abundance. And there also researchers have found babies who were born during the time of food shortage developed epigenetic modifications that lead to later development of non-communicable diseases. Right? So we'll see how that can be explained. Now, being born with low birth weight or intrauterine growth retardation caused by maternal undernutrition or otherwise, results in, along with rapid postnatal weight gain, leads to obesity. At the same time, maternal overnutrition can result in high birth weight and also result in obesity, right? So there is a U-shaped relationship between the maternal undernutrition at the birth weight and late onset obesity. So this obese cohort results in a second generation of obese women in childbearing age who might give birth to babies with high birth weight. And this can go on and on, right? So this is how the researchers think that the obesity epidemic occurred within 1 to 2 generations over the past few decades, right? So the genetics can't explain this epidemic of obesity, but the epigenetic processes can. Right. So this is another illustration where now the grandmother, right, contains the fetus, which becomes the daughter, and within this fetus has the oocyte that give rise to the granddaughter, right? So the exposures of this grandmother can impact the health of the granddaughter and also further transgenerational effect. And similarly, paternal factors also are thought to influence the further generations. So this is an experimental model, but this is how the obesity epidemic is explained. Right. So I told you about the leptin and the adipokines. So the epigenetic modifications occur in these adipokine secreting the genes as well, right? The genes that are responsible in adipokine secretions. So adipokines are considered as important biomarkers of neonatal adiposity, and this disruption of adipokine levels can have permanent changes on the fetal hypothalamus, adipose tissues, and pancreatic islet cells, etc., that give rise to lifelong risk of obesity and metabolic complications. Okay. Right. So with that understanding, with that knowledge on the origins of obesity, we have to utilize the knowledge that we have obtained through research towards primary prevention and primordial prevention, right? So how can we do that? So it has to be a stepwise approach targeting at the critical periods of life with increased um, cell turnover and developmental plasticity, right? So this is a strategic plan, a proposed plan for prevention of obesity. So we need to address the pre-pregnant population, the childbearing age, right? To promote, achieve a healthy BMI prior to pregnancy with good glycemic control and a balanced diet, physical activity, etc. Right? So the pre-pregnancy is a target group, and pregnancy is the next target group to achieve appropriate gestational weight gain, to avoid excess gestational weight gain through regular physical activity, and the infant feeding, childhood child rearing practices have to be inculcated during this period. Right. So pregnancy is extremely important because this is the period where it matters regarding the epigenetic modifications. And then the infancy, to prevent rapid postnatal weight gain. So exclusive breastfeeding is advisable, which is a protective factor towards obesity. And establish healthy eating practices, and responsive feeding is equally important. Mothers have to identify the satiety and hunger cues of the child, right? And also the second year, right? So all these times are important in the causation of obesity. So some of these steps are being practiced elsewhere, but it has to be a general um, sustainable implementation throughout the world. Otherwise, this will not work. Right. So here we are trying to look at the primary and primordial prevention. So infancy and second year, we are looking at mainly the primary prevention. Pregnancy and pre-pregnancy period are mostly for the primordial prevention of obesity. Right. So I think I'm coming towards the end of my presentation. So today I talked through the management and prevention of childhood obesity, focusing first on the epidemic, the gravity of the problem to the world and our country, the definitions, and then how to evaluate a child with obesity, targeting on the management. And I talked through the lifestyle interventions that we can utilize to regarding weight reduction. And then I talked about the primary and primordial prevention of child obesity, which is the way forward to curb this obesity epidemic.